Great. Good afternoon, everyone. Welcome to today's webinar on behalf of the Hepatitis B Foundation and our partners at the Association of Asian Pacific Community Health Organizations. I want to thank you so much for taking the time to tune in. My name is Kate Morars, and I'm a Senior Program Director at the Hepatitis B Foundation and Director of Hep United. We're really excited to present today's session on innovative strategies for using health information technology to identify and manage disparities in high-risk populations. So before we get started with our presentations, I wanted to review just a few housekeeping items and let you know how you can participate in today's Hangout. So all attendees are in listen-only mode. You are muted during the presentations. There is a phone-in option, and the call numbers are shown here. And we will take questions at the end of, towards the end of the presentations at the webinar, at the end of the webinar. And you may submit questions in writing at any point during the presentations by typing them in the question box in your control panel. And we'll be reviewing them as they come in, and we'll finish up with a Q&A period after. And finally, today's webinar is being recorded, so you will receive an email with a link to share the recording or view the recording after today's presentation. So I want to go ahead and introduce both of our presenters. Our first speaker is Dr. Rosie Chang-Ware, who is the Director of Research at the Association of Asian Pacific Community Health Organizations. Rosie will be speaking about a pilot project that collects data, social determinants of health data to look at improving health outcomes. And then following Rosie's presentation, Marika Toyoji, who's the Research Administrator at International Community Health Services in Seattle, Washington, will focus on hepatitis B on a health IT project that looks at collection of hepatitis B data, as well as discuss the impact of social determinants of health on patients living with hepatitis B. All right, so I'm going to go ahead and turn it over to Rosie. Okay. All right, Rosie.
Okay, great. Does that work?
Yes.
Okay, perfect. Thank you so much, Kate. I'm Rosie Chang-Ware again. I'm the Director of Research at APCHO. We're a national association representing 35 health centers and organizations serving primarily Asian American, Native Hawaiian, and Pacific Islander patients. And we're dedicated to promoting advocacy, collaboration, leadership that improves the health status and access of these medically underserved communities. So I want to thank Kate and the Hep B United Foundation for inviting me to speak with you about the exciting work that APCHO, along with our partners at the National Association of Community Health Centers, Oregon Primary Care Association, and the Institute for Alternative Futures, have been working on over the past few years to help health centers and other providers assess and address the social determinants of health. And this is thanks to our funders from the Kresge Foundation, Kaiser Community Benefit, and Blue Shield of California. So today I'll be going over these topics about why it's important to collect data on the social determinants of health, the background of our project that we've been working on for a while, and I'll also talk about how to track some interventions through enabling services, and I'd be happy to answer any questions towards the end. So just to give you some background, why is it important to collect standardized data on the social determinants? So in today's value-based pay environment, payers are increasingly holding provider organizations, including community health centers, accountable for their patient outcomes and their costs. Yet, to ultimately improve outcomes and reduce spending, it's important to treat the whole person, not merely the medical issues that are presented by patients. So this includes the social determinants of health. And unfortunately, current payment structures don't incentivize approaching health holistically and in an integrated fashion. So not only are providers accountable for things that are not specifically clinically related but impact clinical outcomes, but providers also aren't really getting paid for all of those extra things that they're doing to meet the complex needs of their patients, such as the many culture and linguistic services involved in patient navigation of an Asian new immigrant who doesn't speak English. So all of this is largely due to the lack of data on the social determinants of health that patients face. So to be able to truly drive care transformation and improve outcomes, as well as reduce disparities such as hepatitis B for vulnerable Asian American, Native Hawaiian, Pacific Islander populations, as well as for other underserved communities, providers need tools to collect data on the social determinants of health that their patients face. So if you can, for example, document just how complex patients are, both clinically and non-clinically, and capture how your services are different to meet the cultural, linguistic, and other complex needs of your patients, then you can better advocate for different care delivery models and payment systems to ensure that this type of integrated, holistic viewing care is sustained. So what is really driving this need for social determinants data collection? So if you think about it, the environment should make us think about a couple of important questions. How well do we know our patients in order to truly improve their health? And is our care model really set up and sustained in a way to provide the care that our patients truly need? So this framework I'm showing here helps visualize why these questions are so important and how they relate to each other. So as you can see on the left-hand side of the figure, you have your what we call your upstream factors. So those social, environmental, economic, and political determinants of health. These factors all have an effect on the downstream factors, which are on the right-hand side of the framework, such as health behaviors, health conditions, and health outcomes. And there's a lot of research demonstrating the social determinants of health impact on health outcomes, with 50% of health outcomes determined by social, economic, and environmental factors, 30% by health behaviors, and only 20% by clinical care. But there's no one standardized way to collect the data on social determinants. Therefore, little information exists on how many social determinants health individual patients face. For example, which social determinants tend to be found together, which interventions are most effective for which social determinants, how much it costs to care for patients with these needs. And so to transform care, we really, really need this kind of information to inform our services provided and ensure that they are sustained. So that is where our project comes in. So the purpose of our project was to develop a standardized assessment tool that would allow us to collect the social determinants data at the patient level. So this tool, we call it the PREPARE, stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. And PREPARE is not just an assessment tool, but it's a whole protocol of resources and a process to help providers collect and use data on social determinants. So to collect the data, we have both a paper tool and EHR, electronic health record templates. We've also mapped the PREPARE response choices with affiliated ICD-10 Z codes to help standardize the coding of social determinants data and compare the social determinants of different patient populations who see different types of providers. To act on the social determinant needs that are identified, we also have examples of interventions and guidance on how to build capacity to address those social determinants of health. And we'll go into this. I'll go into this a little bit more later in the webinar. Let me move on. So we worked on our project for about 3 years in phase 1, where we're currently in phase 2. So I'll talk about what we did in the development in this first phase. So we spent the entire first year developing the tool, the second year implementing and piloting it at different health centers that had different workflows and different EHRs. And then the third year was spent developing tools and resources and culminating into the implementation and action toolkit, which I'll describe later as a resource for anyone who's interested in collecting social determinants of health. So how did we develop PREPARE? We conducted a large environmental scan of the literature and existing tools in the field to learn more about their content and structure. We also engaged different types of stakeholders for their feedback and monitored and aligned them with national initiatives, including Healthy People 2020, ICD-10, to emphasize the standardization of data collected, as well as with the National Quality Forums panel, on which social demographic factors should be included in risk adjustment, as well as the IOM's committee on which social determinants should be included in meaningful use stage 3 things that all these that are important to health centers. So after this environmental scan, we developed and applied the 6 criteria you see listed here to determine which social determinants of health to include and prepare. So these include stakeholder feedback, which was really important, the burden of data collection, as well as actionability. So what domains did we finally include? So our tool Prepare asked 15 questions to assess 4 social determinants of health domains. The domains are listed here, but I suggest if you want to look in more detail, you can refer to the full tool so you can see a little more detail about how the questions are asked and measured. And I'll give you the resource, but you can find it at nac.com/prepare. So of these 14 core domains, many are common demographic data that are likely collected at any healthcare organization, such as race, ethnicity, English proficiency, which is really important for our communities, insurance, and neighborhood or address. For our community health centers in particular, these and a few others, including veteran status, farm worker status, income, and housing status, they're all reported annually under federal health center reporting requirements in what's called the Uniform Data System, or EDS. So really, potentially these domains can simply be auto-populated rather than newly collected, saving some time in the data collection. And so the other 5 domains align with meaningful use, including education, employment, material security, social integration, and stress. Prepare also contains 6 optional domains, including incarceration history, transportation, refugee status, which is important for our communities as well, safety, and domestic violence. So these are domains that could be particularly important for some communities, such as, of course, refugee status for our Ain and Hopi communities. But as a national project, the group as a whole didn't want to necessarily require all organizations nationally to collect it, although that would be nice. So here at AppShow, we're also considering development of other domains that might be particularly relevant for Asian American, Native Hawaiian, Pacific Islander populations, including country of origin, nativity or birthplace, generation, etc. So here, I wanted to just share with you what the EHR, the electronic health record tool, looks like. Just a reminder, we have both paper format and also electronic format. So this is a screenshot for the GE centricity template to just give you an example of what it looks like. In this screenshot, you can kind of see how the response choices are mapped to certain ICD-10 Z codes that automatically pop up. As I mentioned earlier, these EHR templates have been developed. They're really designed to be available for free so that we can further disseminate this nationally and have a standardized mechanism. And they're all available on the Prepare website, which I'll show you and talk about in just a bit. So let's talk a little bit about the implementation experience. So we had 4 health center and health center network teams piloting our tool. They were located in upstate New York, Iowa, Hawaii, and Oregon. And these 4 teams each piloted on a separate electronic health record, including GE Centricity, eClinicalWorks, NextGen, and Epic. And so these are EHRs. They were chosen because they're used by close to 60% of all health centers nationally. And so as part of their participation in this project, the health center sites and their health center controlled network partners developed implementation resources that are now freely available to anyone who'd like to use the tool. So what have we learned from pilot testing with these health centers? So we've learned from the data collection staff that it takes about 9 or fewer minutes, with most staff reporting about 3 to 5 minutes to collect the data using this Prepare tool. The data collection staff really made the most of patient waiting time. In some cases, for example, data collection took place during the rooming process in conjunction with the case manager and in conjunction with other required assessments that were leveraged. We also learned that staff really find value in the tool. They really like the range of questions being asked and find that it helps build relationships with patients through better understanding of the patients' particular situations and experiences, and it also helps motivate staff. Once they learn about the patient's needs, to really try to help them act on these social determinant needs. Also, as the data collection staff reported, patients also appreciate being asked and are comfortable answering these questions, with some communities using different processes to collect the data. So, for example, in the Native Hawaiian community, their talk story approach was the most culturally appropriate method of asking these questions. And actually, there's a YouTube video that demonstrates this really well that I can point you to. And health centers also identified, as a result, new needs for patients. So for example, some health centers identified new incarceration needs, such as in New York, transportation needs in Iowa. These discoveries really resulted in sort of, aha moments that require health centers to really think through, the new kinds of partnerships and interventions, as well as staffing roles that would be needed to best serve these patient populations. The staff also reported that finding out about patients' risks, unfortunately, also puts an emotional toll on them. Imagine how you'd feel if you were finding out about these patients' risks, and what kind of emotional toll you'd be under as a result. But the bottom line is, Prepare really helps health centers with strategic planning and community partnership development. So I wanted to share with you some data findings as well. One of the analyses we were really interested in was kind of a tally score of the number of social determinants risks that patients had based on their Prepare data collection. So the lines here represent the percent of patients with the tally score indicated on the x-axis. So as you can see in the graph, the tallies tend to range from 4 to 7 or 8 average risks that patients had. So, but one health center in Hawaii actually tended to have more patients with more social determinants factors. But I think it could be because they focused on their Medicaid population who sees care coordinators, so they may be higher risk patients. We also wanted to share with you, an analysis looking at the relationship between the number of social determinants risks, which is the tally score that I showed earlier, and it's linked to hypertension. So we did a correlation analysis between the number of social determinants risks and the number of patients having hypertension, and found a moderately strong relationship. So as social determinants risks go up, so does the likelihood of patients having hypertension. So that was really an interesting result. So I wanted to share with you, how Prepare is already making a significant impact with early implementers at multiple levels. So just to give you some examples, these are many different examples, but I'll just give you a couple of examples here. In Iowa, for example, Prepare, the tool revealed that transportation was a significant issue in the community. So health center staff used this Prepare data to build relationships with local transportation agencies to negotiate bulk discount rates for bus tokens and taxi vouchers. They also geo-mapped where there was the greatest transportation need so that they can advocate for new bus routes to those areas. As another example, in upstate New York, Prepare really revealed that housing was still a significant need despite the number of public and supportive housing services available. So the health center leadership staff used this Prepare data in the meetings that they had with payers and the foundations there to help advocate for more housing services to meet that remaining need. So it's really great to be able to see how this Prepare data has been really important for our pilot health centers to be able to help address these health disparities for their patients. So now that I've talked about the importance of collection of social determinants to identify needs, I'd like to talk about the importance of documenting the interventions that address or respond to those needs. So to really document the value of health centers in meeting the needs of complex patients, it's also really important for health centers to document what they're doing and what services they're providing to help meet those patients' needs. So once they've collected data on social determinant needs, it's really important to also document how they're responding to those needs of their patients. So the non-clinical interventions are what we call enabling services. So together, both sets of data, the enabling services and the social determinants data, really make up the value equation of health centers, which is really important, especially in this this payment reform environment. For example, only demonstrating that your patients are sicker and experience more social determinants of health barriers doesn't really assume or demonstrate the extra unique services as well as the necessary reimbursement that these providers, these health centers are doing and requiring to address their patients' needs. So for example, knowing about an Asian patient's language barriers is not enough. You need data to show that you're actually employing your multilingual staff to help patients better understand their health care. And this costs you extra money to be able to hire these multilingual staff. But it is critical because otherwise, how will your patients, come in for preventive care? Your patients would instead not come in for preventive care and just overuse the emergency room if you didn't have these types of critical services for your patients. So you can say the same for other types of non-clinical interventions as well, such as I'll tell you about some of those ones coming up. Many different types of enabling services that are helpful for high-risk patients. So here it is here. So this is why APSHO had developed the enabling services data collection tool and protocol. So this tool collects non-clinical interventions in 9 different categories that were vetted by a group of health centers and experts as the most common categories that could be broad enough to collect nationally, but also that health centers can individually customize as needed to show further detail. So the tool also collects, not shown here, but provider of the service, encounter type, whether, for example, the encounter was done face-to-face, by phone, or off-site, for example, the appointment type, the scope of service, whether it was individual or a group appointment or meeting, what language the encounter was provided in, especially if it's not English, and most importantly, the length of service, so how long the encounter took with the patient so that we're able to draw better conclusions about the cost of these services. Here's just an example of one of the enabling services, EMR, electronic health record templates. You can see the services on the left side and the drop-down box for the minutes here. If you want to see the full tool, we have the systematic data collection tool and protocol as well available on our website, as well as the full data collection implementation packet on our website, enablingservices.apsho.org, as well as on the Prepare website. We have a chapter in the Prepare website called Track Your Interventions that is really helpful for better understanding this. So, so this is, I just wanted to share this conceptual framework. This is how we see it all fitting together. So it's important to collect both sets of social determinants and enabling services data to complete the overall framework. We see social determinants acting as a predictor to impact health outcomes by affecting clinical care-seeking behaviors, and enabling services and other non-clinical interventions which are designed to address social determinants act as a moderator to improve appropriate care and clinical health outcomes. So collecting both social determinants and the enabling services data and connecting it to patient clinical data is really crucial in contributing to this value equation of health centers and other providers, and showing the importance and uniqueness of health centers that provide these critical treatment for high-risk populations. Okay, so let me share with you some resources that we have available. Here's where you can find lots of resources related to both Prepare as well as our Enabling Services Accountability Project and the contact information for further questions. So this is, you can take a look at this further and get the contact information once Kate sends this out to you. This is just, I wanted to share with you the content of our Implementation and Action Toolkit online. As you can see, it has a wealth of resources. Again, these were developed primarily, or tools that were used primarily by our pilot Prepare teams, so that they have they have wide applicability for others if they're interested, if you're interested in using if you're interested in implementing Prepare. We kind of, there's 10 chapters. We kind of separated them by, assessing, addressing, and responding to social determinants of health needs. So you can take a look at that. It's a really great resource. It also includes the EHR templates I talked about that you can download and use if you'd like. So here I just wanted to illustrate that Prepare really is a national movement. This graphic, I didn't get a chance to update it, but it's a little outdated. And at this time, all states have now expressed interest in using Prepare, the social determinants of health data collection in a standardized way. So this is really great. We're really excited that folks are really interested in this. Imagine if everyone collected the standardized data on the core social determinants of health as well as enabling services. Just imagine what we could do in terms of research, in terms of advocacy, in terms of informing policy, payment, and care transformation, and accelerating community change to really reduce health disparities for underserved populations. So this is my contact information. Now, with that, I'd like to, again, thank you so much for listening in to this presentation. I'll now turn it over to Mariko, who will talk more about our collaborative Hep B that looks at some of these important social determinants of health. So thank you so much.
Thank you, Rosie.
Hello there. Hi, I'm Mariko Toyoji, and I'm with International Community Health Services. We're a federally qualified health center in the Seattle area in Washington. And I'm here today to talk about a EHR data-driven program called the Hippie Project that ICHS and APCHO collaborated on together to help us reduce hepatitis B disparities among APIs. So today I'll just give you a quick overview of where I'm taking you all. So first we'll explain a little bit about the project, hepatitis B as a health disparity, as well as go over the intervention, our evaluation, and then some lessons learned for you all. So let's see, the Hippie Project is an NIH-funded community-engaged research pilot. And basically what we were aiming to do is to leverage our HIT, our health information technology systems, to improve hepatitis B screening, vaccination, and linkage to care. So our partners are APCHO and ICHS, and then our primary investigators were Rosie Chang-Weir, who you just heard speak, as well as Michael McKee, ICHS's Director of Community Partnerships and Health Services, as well as Dr. Cha Wong, who is an infectious disease specialist at Virginia Mason Hospital, and then also a consulting physician at ICHS. So I just wanted to give a little bit of background about International Community Health Services. So we started about 40 years ago in 1975 as a storefront clinic in the Seattle Chinatown International District, and now we've expanded to 4 primary care clinics, school-based health center, as well as other satellite clinics as well. We provide not only primary medical care, but also dental, behavioral health, and health education services. And we served about 25,000 patients, and they're largely Asian American, Pacific Islander immigrants and refugees. And we have a substantial number of people who are limited English proficient and need interpreter services, and maybe uninsured, homeless. And we have about 7% of our patient population has chronic hepatitis B. So as many of you on this webinar are probably already aware, hepatitis B is a substantial global health issue, and here in the United States presents as a major health disparity among Asian Americans and Pacific Islanders. And so the United States Preventive Services Task Force recommends that people born in countries with greater than 2% hepatitis B prevalence get screened for hepatitis B. So on this map, it's the dark and medium shaded parts of the world. And so at ICHS, we wanted to actually take this guideline and operationalize it in a meaningful way for our care team and for our patients as well. So in an ideal world, we would have already have had all of our patients, we would have data on their country of birth or their mother's country of birth, but unfortunately, we at the time of this project had not started collecting that data. So what we did instead was that we looked at the data that we did have, and we wanted to see how we could use it to approximate possible risk for hepatitis B according to that guideline. So what we did was that we actually took a look at our data on race, and according to this race, ethnicity, and language data, we were able to put people in kind of either into a broad risk category, where their care team would then receive enhanced data about hepatitis B. So, for example, the way this algorithm would work was that we would look at race data in our EHR system. If you were Asian or Native Hawaiian or other Pacific Islander, we would include you in this hepatitis B risk category to receive interventions. But let's say that your race was listed as Black or African American in our EHR system. We would then take a look at your ethnicity, and if your ethnicity in the EHR system were listed as something like Somali, then we would include you in the risk category. But if your ethnicity was listed as Black African American in the EHR, then we would take a look at your language. And if your language were something like Amharic, then we would include you in the risk category as well, because that would indicate that although your ethnicity may not say exactly where you're from, it would indicate that possibly you were born or had immigrated from a part of the world that had high hepatitis B prevalence. It would therefore be at risk. If your language were listed as English, we would not put you in that same risk category, although your provider may still evaluate you for other risk factors associated with hepatitis B. So we used SQL code, and our IT staff was able to integrate this EHR data and make it an actual living algorithm through live reports using SQL. And then we took that data, that initial risk data, and among those who were considered at risk based off of their race, ethnicity, and language data, we then provided what we call our Hippie interventions. And we developed these IT interventions with basically our needs assessment from our staff. And so we went to them and asked them about what their challenges were, what their needs were, and how EHR data might be able to support their work on hepatitis B. And what they recommended to us is that they wanted a program that used a team-based approach in addressing hepatitis B. So they didn't want it to be just provider-focused, but they wanted it to rather have different parts in the care team where people could act on hepatitis B. They also wanted us to incorporate this program into our existing clinic workflows. We're a community health center. Time and resources are tight, so they felt like really it should integrate well to address and meet our actual capacity for change. And then also they wanted us to improve our systems for following up with our patients who we had already identified have chronic hepatitis B. So what we did is that we created 4 key interventions, which I'll go through individually one by one. And then in addition to these 4, it's not an IT intervention, but it's also very important. We also provided training on all of use of these tools and evidence-based guidelines on viral hepatitis management and prevention. So one of the interventions that we utilized, we added hepatitis B specific information to our Huddle Sheet. And what our Huddle Sheet is it's basic information on every patient. It's used as a communication tool between a provider and a medical assistant, and provides kind of a summary of whom they're seeing that day. And so this Huddle Sheet of what we have is we have a patient's surface antigen, surface antibody dates and results, as well as information on their last dose of vaccine. And then we also provide additional information regarding hepatitis, chronic hepatitis B management if a person is surface antigen positive. So what this does, that alerts the care team to somebody's status and then indicates whether they may need testing or vaccination or follow-up care for chronic hepatitis B. We also wanted to create an information feedback loop on hepatitis B. So on our monthly QI reports, we added a measure for hepatitis B screening that shows the proportion of a provider's panel that has been screened for hepatitis B. We also integrated evidence-based guidelines on chronic hepatitis B care management. And so this protocol gets uploaded into every chronic hepatitis B patient that we have and indicates to the provider whether they're due for the necessary tests. In addition to that, for our chronic hepatitis B patients, we created a population health management report that allows our health educators to actually follow up with our patients living with chronic hepatitis B and basically creates lists that they can sort, and then also because many of our health educators are multilingual and they provide services in language to our patients, they can actually identify and pick the languages that they speak and create a specific list as well. So what this does is that it lets a health educator know if somebody needs to come in for an annual appointment, if they need a specific test, or if they need to come in for a health education session as well. And so what this does is that it allows our team to kind of engage with patients if a patient hasn't been coming in, to re-engage them with care, and then also to assess what other needs they might have or barriers. So for example, if a patient hasn't missed their last appointment for hepatitis B follow-up, if they mention something like it was a transportation issue, our health educator can then connect them to a patient navigator to help them address that as well. So it's a nice way and it's an effective way of following up with our patients who might have multiple needs and are managing a chronic condition as well. So this is kind of a schematic of how the whole program works. So we have EHR data up here, and it comes from various sources within our system. It goes to a SQL reporting server that then identifies risk and then also major hepatitis B statuses. And then according to status, people receive different interventions through their healthcare team providers. And those are the 4 interventions I mentioned already that support advanced planning, decision support, as well as population health management. And through these interventions, we hope to improve screening, vaccination, and linkage to care as well. So we want to see if this actually works. So we put our resources also into evaluating it. So basically what we did is that we looked at 6 months prior to implementation, and then another 6 months after implementation, and then we looked at a different section 6 months later for our chronic hepatitis B management. And the reason why we have a phased evaluation is because we really had to assess in clinic whether or not we had capacity to implement all 4 interventions at once, and really we didn't. So we decided to break it up into a prevention phase and also a chronic hepatitis B management phase. So that's why there's 3 different kind of snapshots that we're going to look at in our evaluation. So just to give you some background on our study population, these are all the patients who we were considered part of the study. So we're patients who presented to the clinic during our time periods of interest that are aged 18 to 70. And so we just have the basic breakdown of sex, and which stayed very consistent. The overall number increased a bit over time, and then also our 5 largest ethnic groups that were in the study population. There were more, but the list is very long as we have a very diverse patient population. But as you'll see here, a large majority of our patients are either ethnic Chinese or Vietnamese. So our age of our study population remained fairly consistent over time as well. And then here we have our chronic hepatitis B prevalence among our sample. And so it actually remained pretty consistent, but I have some other data about specific to the interventions as well. So one of the things that we wanted to look at to see how our testing went. And so I don't know why this isn't showing up, but before, 6 months prior to implementation, we had 21% of our patients who came into the clinic for appointment and needed hepatitis B screening received it. And then post-intervention, that number went up to 28%. So this was a statistically significant difference. As well as our vaccination results, before program implementation, it was about 13%, and then post-implementation, that number went up to 27.3%. So these are adults, and as many of you probably know, getting adults vaccinated for anything is quite difficult. So we were able to at least get them one more dose of vaccine, and that percentage doubled as a result of the intervention. We think a lot of this has to do with our great medical assistants. They actually have the ability to recommend vaccinations to patients, and we think that the Huddle Sheet really assisted them in identifying who needs to be vaccinated or receive another dose. So we also took a look at our linkage to care outcomes, and these were specifically for our chronic hepatitis B patients. We looked at 3 major linkage to care factors, and those were receiving a hepatitis B DNA test. So the numbers went down percentage-wise, but overall, the numbers of patients receiving these services went up for both hepatitis B DNA or ALT within 6 months of their visit. We also took a look at health education, and that actually increased substantially among our newly diagnosed chronic hepatitis B patients. So we also wanted to, so that was our official evaluation, just looking at those 6-month snapshots. And so I wanted to give you all kind of a broader look at our data from 2013, so before we implemented this program until last month. So we've seen a very large increase in the number of hepatitis B screenings that we are administering to patients. So if you look here, each one of these points is 1 month and then represents the number of surface antigen tests fulfilled at our clinics. And so our monthly average almost doubled during that time, and then and this actually results in a substantial number of people being identified as surface antigen positive. So for example, in 2013, we identified about 80 patients who were surface antigen positive, and in 2015, that number went up to 159. So screening really does make a difference in identifying surface antigen folks, and then with that, we can then get them into care and get them managed and hopefully prevent subsequent cirrhosis, cancer, or transplant. Another kind of snapshot and look at our data on a population level. So what we have here is each of these bars represents the percent of our patient population and their hepatitis B status. So we have our chronic not immune, so that indicates that somebody would need vaccination, and then documented immunity, so either surface antigen negative and surface antibody positive, or surface antigen negative with all 3 vaccine doses. So really the story here is in the number of people who have an unknown hepatitis B status. So before we started this project, about half of our patient population, we were not aware of their status in the EHR system. And then now this past year, that number has gone down to about 1/3. So we're really proud of the progress we've been able to make, and how we've been able to empower our staff to take better action on hepatitis B. So some of our lessons learned was that having site-based champions really made for a better intervention, and then also helped us with adoption, uptake, and then as well as improving the program over time. We acknowledged that a care team-based approach was essential to the program working and being sustainable. As well as resourcing our own IT capacity made a large difference in not only the program implementation development, but also keeping it going, and then also benefited the organization as well with our enhanced skills that we have now on staff. We also acknowledge that addressing EHR data issues is challenging, but really can pay off in the long run. And then to knowing another analysis demonstrated that patients with insurance were more likely to receive screening and vaccination, which seems obvious, but that insurance and access to care really are still large barriers for people in getting important preventive services. And then too, that FQHCs, given resources, can develop and innovate and produce programs that can help address health disparities using their data. So just some quick steps for implementation for all of you to take away. So if you're thinking about doing a program such as this, take a look at your data and your organizational capacity, and then think about ways to expand your capacity to collect relevant data. Something like Prepare is an excellent resource for that. Also take a look internally and see where you might need to increase capacity, where you need resources or training. Also look at what you're currently doing in your clinic or your programs and see where there's opportunities to provide hepatitis B data. Develop team-based approaches so that staff at all levels can assess risk and take action on hepatitis B, and then also know that training is key to doing any of these things, and particularly for empowering staff. As well as education for our patients. So health education, what it does is that it empowers our patients, families, as well as communities that they live in as well. So I want to thank you all for listening in today and hearing about our program. And I guess we'll turn it over for questions. This is my contact information here. If you have additional questions regarding the program or ICHS, feel free to email me.
Thank you so much, Mariko, and thank you to both of our speakers for that really rich presentation. We'll now begin the Q&A portion of our webinar. So as mentioned in the beginning of the webinar, we'll start by answering questions submitted to us via the chat box. So if you'd like to submit a question now, please do so using the questions field on your screen. And so we do have our first question, and this is for both of our speakers, I think. And Rosie, feel free to start. The question is, how can we get these tools to use with our partner community health centers? And in follow-up to that, how can we get them to integrate this into their existing EMRs and electronic medical records if there is no funding?
Yeah, great question. Actually, maybe it's a good time to talk a little bit about, what we're currently planning for phase 2, because these are things that, our phase 2 of Prepare is all about spread and dissemination and helping with these kinds of capacity issues. Well, first of all, you can, I think the question was, how do we get our partner health centers to get these tools? I'd really encourage folks to go on the Prepare website, nac.com or nac.org/prepare, and look at all the resources. There's information about, there's a chapter on capacity building as well. So in the funding question, in phase 2 of Prepare, we're launching a national Prepare Learning and Action Network called the Plan, in which we would share best practices and lessons learned develop a live university where users can access trainings, experts, and other users to facilitate implementation. And so we're through this process, we're going to be working with state-based in developing train-the-trainer approaches. So there will be some funding available to be able to help health centers or other types of providers with this. A lot of times, actually, for example, currently states and foundations have really just contacted us to see how we can help the health centers in their state to implement this because they believe it's so important. So I'd encourage you to reach out to your state foundations or local foundations or other types of funders to talk about the importance of this for your providers, and work in concert with them to find resources to be able to do this. I think the health centers that were engaged, there's, like I mentioned, every state and many, I think we've got a listserv of over 2,000 or 3,000 and growing every day. I think folks just really see the value of this, especially in this value-based pay environment and in this, this current administration and payment reform. They see the value in this and really just believe in the importance of this to be able to improve their patient population's risks. And the data, like I mentioned, in terms of the examples of how the health centers have used the data, it's really helped them to think about working with their community partners in terms of how to address these needs that are now being identified that they didn't necessarily know about in the past, and work to really work together to develop interventions, like I mentioned, the new bus routes, the taxi vouchers, working to provide these really identified interventions. And so stay tuned for phase 2 of Prepare. We're mainly working with state PCAs and health center controlled networks because we want to be able to disseminate this broadly. So we believe that empowering the states to be able to work with their local health centers will be a more powerful way to spread this valuable tool. So again, I'd encourage you to work with your state foundations. We're already doing this. A Texas Foundation and a California Foundation reached out to us to do this. So we've already started working with those states to and the foundations have provided the funding for these health centers to be able to implement social determinants. So I hope that was helpful and answered the question.
Yes, thank you. And Mariko, do you want to comment on integrating Hep B?
Yeah, I think that Rosie just presented some great opportunities for collecting data and then also utilizing it. And I think too, we were fortunate enough to have an NIH grant to develop and implement this program. But I think that at other health centers, even with limited resources, it's possible to create a hepatitis B population health management or prevention program. I think too to think of it from the perspective of quality improvement is helpful, and to think about where resources might be in that vein or among your own quality improvement team or department at your organization. It's helpful to think of this as an investment both in IT and quality, and then to really start with looking at data collection and quality, and then moving from there to see where you can integrate meaningful hepatitis B data into your workflows. So our program isn't necessarily, it's not as cleanly packaged as Prepare, where you can integrate it directly into a number of EHR systems. But I think that if you do have capacity for things like SQL reporting at your organization, that it's a great way to do real-time reporting and to and business intelligence work too. So I think that it's possible to really make improvements where you can, even with limited resources at organizations such as FQHCs. If you have specific questions about our program, feel free to contact me and I can share information directly too.
Thank you. Our next question is, this is for Rosie. How did you overcome language barriers when surveying patients for Prepare?
Yeah, that's a great question. So in this first phase, as much as we wanted to at AppShow really wanted to test a non-English language version, we as a I'm working with other partner collaborators that serve the general population in national organizations, and so we wanted to start with they wanted to start with piloting the tool in English, but since then there's been a lot of interest in looking at translating it to non-English languages. We actually have a Spanish tool, and we're actually in one of our state-based projects, foundation projects, where we're definitely considering and we'll be piloting it in a Chinese language. So in our first phase, we wanted to start with the general, and then now we're getting more specific. So we're really excited about being able to extend it to non-English language populations, because we at AppShow know how critical that is to be able to reach the truly underserved patient populations.
Great, thank you. And then I guess for both of you, can you talk about some of the challenges in implementation, whether it was with the external audience, with the patients, or whether it was internally in terms of integrating it into your existing the existing health center EMRs?
Sure.
Marisa, do you want to start? Oh, sorry, go ahead.
Go ahead, Marisa.
Oh. Yeah, so we ran into a number of challenges, everything from just dealing with different iterations of data, so EHR systems change, lab systems change, and so looking back at historical EHR data, sometimes it's difficult to fully integrate older data with newer systems. Other challenges that we ran into that needed to be addressed was that sometimes we think in kind of the EHR data world, we think of ICD-10 or formerly ICD-9 as kind of the catch-all, but really we found too that it wasn't necessarily a reliable way to identify all of our chronic hepatitis B patients, so we had to pull data from multiple sources and kind of cross-reference those as well. As well as lots of times important data can be captured in notes or fields that aren't necessarily directly queryable by algorithms or reports, and so there can be a disconnect between what a provider sees in a patient's chart and what shows up on a report. So those are ongoing challenges that I think that all healthcare organizations that use EMR face and are important to acknowledge and know where there might be some challenges with your data, but also where you might be able to find some creative fixes or have capacity to correct some of those issues in EHR.
I know we're at time, so I'll just briefly say for Prepare, there's lots of questions about how do we do this without we don't have a lot of time with the patient. How do we do this, implement this Prepare social terms data collection without increasing visit time? How do we fit this into our workflow? The key was really trying to find value added time. So for some of the piloters, they did this, in the waiting room during the rooming process, or sometimes they did it after the clinic visit because they needed more time. But also, there's a lot of different assessments that health centers do, and so we encourage them to really look at their workflow and to see, what redundancies there might be to be able to leverage, all their different data collection mechanisms to see, what more efficient way that it could fit into their workflow. So we did a lot of workflow analyses, doing the 5 rights. I could talk more about that, or if you have any questions about that, you could contact me. But yeah, we did some workflow analyses to try and figure out, how to best incorporate this. And so, and then in asking them about how long it took, they didn't really find that it took a lot of time, because for the majority of patients, because a lot of it was already collected, within their existing health center assessments, like the UDS, or even in some of their existing health risk assessments or patient activation measurement, et cetera. So there's definitely solutions, and I'd encourage you again to look at the implementation and action toolkit online. I think there's a chapter or summary on some of these things and what solutions we found.
Great. Thank you so much. Yes, we are at time, so fortunately we're going to have to wrap up, but we have taken notes of your questions and comments. So if we were unable to answer anyone's questions today, please don't hesitate to contact us directly at connect@hepiunited.org. And lastly, I want to thank Rosie and Mariko for the rich information that you've shared, and I know that most of the folks on the call will have be contacting you for many more questions related to integrating into their own systems. So thank you so much for participating today. And here's our contact information. Please visit the Hepatitis B Foundation at hepi.org and consider joining our Happy United Coalition at happyunited.org. And finally, please look out for a message as soon as you close out the webinar for a quick survey. And we would greatly appreciate your feedback on our webinars. And we will be sending a copy of Mariko and Rosie's slides to everyone that registered or attended today. So we will have their contact information as well as a link to the slides. So thank you all so much, and have a great rest of the day.
Thank you.
Yeah.